Hi y'all, welcome back to my channel. My name is Jeffrey, and today I'm going to go over your cholinergic drugs, okay? Your cholinergic drugs. Remember that these are going to deal with acetylcholine as a neurotransmitter, and this is going to be in your parasympathetic nervous system, okay? So for your cholinergic drugs, you can separate them into two major broad categories, and the first one is going to be your agonists, and the second one is going to be your antagonists, okay? And in your agonist, there's going to be two different subtypes. You're going to have your direct acting agonists as well as your indirect acting agonists. And in your direct acting agonists, you can have two subtypes as well. And the first one is going to be your choline esterases, okay? And the second one is going to be your natural alkaloids, I believe. Yes, natural alkaloids. And the way I try to remember this is for your choline esters, it's going to be BAM, and for your natural alkaloids, it's going to be NP for nurse practitioner, because they administer your natural alkaloids. Okay, so for your choline esters, when I think BAM, these are the drugs I'm thinking about, right? So it's going to be bethanicol, it's going to be acetylcholine, and it's going to be methacholine. Okay, and the way I remember these drugs is they all have a chol in them, and that's going to correspond with that choline ester. Okay, for your natural alkaloids, it's going to be nicotine as well as pilocarpine. Okay, uh, yeah, I don't have any tricks to memorize those. Sorry. And then for your indirect, these are going to act on your acetylcholine esterases, and they're going to inhibit them. So remember, acetylcholine esterase is the enzyme that breaks down acetylcholine, and you're going to receive more acetylcholine in that synaptic terminal. Okay, so for your for your three subtypes, it's going to be organophosphates. Organophosphates here, you're going to have ephedronium right here, and your third one is going to be carbamates. Okay, for your carbamates, there's going to be it's going to be ppn. Ephedronium, just remember it the way it is. It's perfect the way it is. And for organophosphates, I kind of just remember just the names. So malathion, as well as the sarin. Okay, and the way I remember malathion is because organophosphates are extremely toxic for you. They're found in nerve agents as well as your pesticides, right? So your typical cases are going to be a farmer comes in or somebody's doing their yard and they're trying to spray pesticides and whatnot. But malathion, malicious organophosphate. Okay. For your carbamates, this is going to be your neostigmine, your peridostigmine, and your physostigmine. Okay, and the way you remember this is just stigmine. Like, what more can I say, right? Um, all right, so now that we have all the agonists down that we are going to cover in this video, let's talk about antagonists. So there's going to be two major types. The first one is going to be your presynaptic antagonist, and this is going to be Botox. Okay, so oh gosh, I cannot spell. It's going to be your Botox, okay, and it's also called botulism toxin. All right, and then your postsynaptic, and your postsynaptic is going to have two subtypes as well. It's going to have your muscarinic, as well as your nicotinic. Uh, And the way I try to remember muscarinic is this acronym ACIT, and nicotinic is going to be TSH. Okay, TSH for me is just like thyroid stimulating hormone, and for some reason that sticks. Okay, so for your muscarinic, the A stands for atropine, the S stands for scopolamine, I believe, scopolamine. And then your I stands for ipotropin, tropium. Okay, and then your last one is going to be your tropicamide. And there's no easy way to remember these. They're just really weird names. That's all I can say about that. And then for your nicotinic, it's going to be tubocurarine. Has like two R's, which is really weird. You have your succinylcholine, as well as your H, which is going to be your hexamethonium. So the way I remember these is just that the names are just kind of outrageous, and they're literally like the weirdest names in the world, and that's how I remember them. But yeah, so these are going to be your different drugs for your cholinergic. All right, so now I have a more consolidated and more neat version of the cholinergic drugs. And you can see here that they all have different functions. So let's just go over them real quick. Remember, we were talking about choline esters a little bit before, and it's going to be your bethanechol, and your bethanechol is going to be a muscarinic receptor agonist, and it's going to result in urinary retention. Your acetylcholine is mainly used in constricting your pupil. Your methacholine is going to be for the diagnosis of bronchial airway hyperreactivity. And what that means is just diagnosing asthma, okay? And the way it does that is that it causes this bronchoconstriction, right? So it's going to stimulate those M3 receptors, and as a result, your because of that stimulation of your PNS, remember, it's going to constrict your lungs, your bronchioles, and as a result, those who have asthma but don't know it yet are going to have a harder time breathing than those who don't. Okay. For your natural alkaloids, these are going to be tertiary amines, and nicotine on low doses is going to stimulate your autonomic ganglia, and at high doses, you're going to lose selectivity because of continuous stimulation. Okay, for your pilocarpine, it's going to treat close angle glaucoma as well as stimulate salivary glands. Okay. Um, so for your indirect, remember these are acting on your acetylcholine esterases. So for your, let's just talk about edrophonium first. Um, oh, it was edrophonium. I wrote ephedronium. Oh, well, I'm so sorry about that, guys, but it's edrophonium, and these are going to be quaternary ammonium structures. These are not going to enter your blood-brain barrier or affect CNS function. And these help diagnose myasthenia gravis. Myasthenia gravis is a condition where you have your muscles drooping, for example. And with edrophonium, since it's reversible, it's only going to act for a short amount of time, but that patient will regain function of basically everything. So um, this is a prototypical example of diagnosing myasthenia gravis, and then these are going to be helping, or these two are going to be helping treat that. Okay, so physostigmine is going to be a tertiary amine. It's going to stimulate your CNS as well, but these are going to be your anticholinergic overdoses. So it's going to help reverse the effects. So for example, if you have an overdose of atropine, which is a PNS antagonist. And then you have your pyridostigmine, it's a quaternary ammonium, and it's going to be the best treatment for myasthenia gravis. And then you also have neostigmine, which is also a quaternary ammonium, and it functions to retain your urinary retention, as well as reverse neuromuscular block, for example, after surgery. So when you need to wake the person up and you need them to be able to move afterwards, you prescribe them, you give them neostigmine. For your organophosphates, just remember malathion, we touched on that it was a pesticide, and then sarin is going to be a synthetic toxin. Okay. Moving back to the antagonists that we were talking about before, so for your presynaptic, these are going to block the release of acetylcholine. So for your Botox, it's going to decrease those muscle spasms. All right. Postsynaptically, your muscarinic, you're going to have atropine, and atropine is a tertiary amine. It can induce CNS effects, but basically it's a cholinergic antidote. So for the agonist, if you take too much of the agonists, then you can actually block it with the atropine. So atropine can block respiratory secretions before surgery, and it can also, for example, if you OD'd on bethanocal acetylcholine, for example, it can reverse those effects. And then remember, you can reverse effects of atropine poisoning with physostigmine. Okay, so I mean, if you think about it, it makes sense because the agonists and antagonists are going to be working against each other. And then you have your scopolamine. This is going to be for your motion sickness mostly. Your ipratropium is going to be for bronchodilation. So if you're trying to diagnose asthma, or if you're trying to help treat asthma, for example, you can give this to patients with COPD or asthma. And then your tropicamide is going to dilate your eyes for fundoscopy. So um, it's going to prevent that PNS innervation, and as a result, your eyes are going to be dilated because remember, your PNS constricts your pupils, right? And remember, for these, just don't prescribe for glaucoma because glaucoma is increased pressure in your eye. If you dilate your eyes, for example, or if you dilate your vessels, for example, you will exacerbate glaucoma and maybe potentially lead to blindness, okay? Nicotinic, you have your tubocurarine. Basically, this is to relax your muscles. Your succinylcholine, it's going to be an agonist, and it's going to actually be such a good agonist that it leads to the desensitization of your acetylcholine receptors, and as a result, it's going to be an antagonist, okay? And you typically use this for intubation or ECTs, okay? Your hexamethoniums are going to be your ganglion blockers, and these are going to be for hypertension. We don't prescribe these anymore. There's better drugs for that. But these are going to be your different cholinergic drugs. I hope that this video has been helpful, and I hope that you learned something. All right. Thank you. Have a great day.